I want to start just by reviewing out loud. If those of you don't have your program, I'll just read our problem statement here now. But if you do have your program, go ahead and read along. Get ourselves sort of level set.
How are you?
Blue. According to the Healthcare Authority's RFI results, larger provider systems have made progress towards the adoption of value-based payments. However, even large provider systems encounter barriers to getting additional providers to join the network. Is market consolidation the only way to address provider adoption of value-based payments? Clearly, this is meant to stir discussion and get things going. Within the context of this question, specifically related to value-based payments, specifically related to market consolidation, I want to first ask for your feedback related to the plenary session. And if you heard things from the conversation up here that spoke to consolidation in VBP, or if there were some notable absences. Any feedback first from what you heard this morning before I call on you? And I'm going to Phil Donahue this for those that remember Phil Donahue. I'm just going to walk around and stick the mic in your face. Yes, ma'am.
Caroline Whalen, I'm with King County. One of the things that I heard Rick talk about was the need for a transformation of clinical models. And I think that's very difficult to do if you don't have a larger group in which to do it. I mean, you've got to have agreement across a pretty broad spectrum of care. And I don't think that there's been a lot of funding or emphasis on, how important that work is.
There's sort of two contradictory things there, right? Size and consensus. Is there enough work in this space around, because you have spent so much time on this topic, around cultural development and alignment amongst organizations or amongst sort of plans and providers? Does healthcare spend enough time on culture?
I don't think so. And I also think that I agree with kind of an underlying thread that was through the plenary session, and that is that if you remove the financial barriers, that I think transformation is a lot easier. I watched what group health did with moving to patient-centered care in their clinics, and they were able to do it quickly because the finances were aligned.
Bob from the Medical Association. One of the things that I'm struck by is we're at that point where you're using value-based payment as a term. It feels a lot like managed care of the 90s, which is, what do you mean by that? It's a question of, when talking with various providers at various levels, some I have no idea what you're talking about. I don't know what it means from a clinical perspective. I don't know what it means from an operational perspective. So getting some standardized definition, just saying, volume to value sort of thing it's a good catchphrase, but again, from a real sort of, just tell me what I have to do, I think that's still missing at this point. Yeah. Okay. And just in reaction to the general session this morning, we see a lot of sort of anecdotal one-to-one relationships. Rick talked about what every clinic was able to do with Primera. It has the feeling of a sort of, if you've seen one, you've seen one kind of situation, as opposed to here's a general template of how you can make this a reality. So just some reaction.
Other bits of feedback?
I got kind of piggybacking on Bob, and who's it a value to? Is it a value to the insurance company? Is it a value to the provider? Is it a value to the patient? Because we all have different goals, we all have different values. So who is this actually going to be a value to?
Anyone else want to jump in on this? Hiroshi?
Hi, Hiroshi Nakano, UW Medicine Valley Medical Center. I think just to answer the question directly about consolidation, I think the answer to that is really no. But I think the conversation of the earlier comment from Carolyn about culture is huge around that, and then to transform that culture, you're going to have to change the payment system. I mean, I don't think the culture comes necessarily before the payment system, just because in a daily, day-to-day, figuring out how is our organization going to move forward, how is it going to survive, if you don't have the financial incentive that comes along with it, to me, it's almost an impossible conversation to have.
So let me ask Hiroshi, because you've been on the sort of independent side and then the larger system side, one way to take Bob's comment is that if you're a small clinic or an individual provider or practitioner, it is extraordinarily difficult to also be a great administrator and a great CFO and a great, regulatory compliance officer. Doesn't that sort of necessitate significant consolidation? And to Rick's point about the complexity now being even greater than it was, if we can imagine that, doesn't that sort of require that providers just provide care and that administrators do the administration? And therefore, you have to have greater scale to be able to do this.
Well, yes, I mean, the challenge for a small practice is huge in this area. But I really think that there are ways to create new relationships. I mean, when you think about comments around accountable communities of health, those types of things, and the linkages and the partnerships that we're going to have to be able to create in order to meet the triple aim or the quadruple aim, we're going to have to create partnerships anyway. And that doesn't mean that, say, Valley all of a sudden gets into the housing business, right? But certainly I could see relationships where Valley works with providers of, subsidized housing to provide a better environment to improve the overall population health care. I think the same thing happens at the care health system delivery level. Maybe we don't have a certain specialty that we don't provide at Valley today, but we can certainly partner with somebody to provide that service to our hospital district, right? I think it's incumbent upon a lot of health systems to work with all those providers of care to provide the infrastructure, because the scary part of all this and the investment part of this is the infrastructure. How do we take the data? How do we take the care management systems? How do we provide new models of care teams in a way that we won't go broke doing it?
Let me ask this question. If we think of market consolidation within the context of this question as a means to an end rather than an end unto itself, not everyone always thinks of it that way, I think, but if we think of market consolidation as a means to an end, and that one of those ends is improved value, are there other means to that end at an organizational or system level? Are there other ways to get to improved value and the scale required to get there outside of significant market consolidation? No one else has their hand up. Bob, go ahead.
By default. I think really what's going on, if we're thinking in terms of provider adoption of value-based payment, market consolidation is one way, but ultimately a word that you used was scale, and really this is about economies of scale. The challenge, what is it that a large system has that enables it to participate in this marketplace? They've got infrastructure, they've got staff, they've got expertise, they've got access to capital, they have IT systems, so they're able to play. And the further down you go in the size continuum of a practice, they don't have those economies of scale. They can't do that. They can't hire enough people to do that. But again, interestingly, when you've been at this sort of on the merry-go-round long enough, the terrain starts to look familiar. That, much like we're seeing, in the past of independent practice association, IPAs, it's like, no, you can keep your own tax ID number and be your own practice. Let's figure out a way that we can come together as some sort of hub. Let's have some centralized IT, centralized purchasing, things of that nature. In other words, how else can you get to economies of scale rather than market consolidation? So I think we need to keep that in play as options as to help small to mid-sized practices play in this marketplace going forward.
Joe Rosa, Kitsamanala. Building on your last comment, because I agree with you, one of the whole concept that we're building through consolidation too big to fail. Just today, CHI announced that they signed a letter with Dignity, which has 22 healthcare systems across 22 different states. So Catholic Health Initiative, Dignity, that's going to be a humongous organization. So what happens though is that when they get that large, they have a bottom line, and they can actually then toss out hospitals that are low performing. And that's a bigger difference than if that is a community-based hospital, which is serving that community. They're less likely to go away. If it's oftentimes I find small nonprofits stick through thick and through thin, through bad weather, through good. But when you get into the larger conglomerates, then in order to maintain that economy of scale, that leverage, it comes at the cost of sometimes the frontline providers who simply, well, you're not essentially making the payments or the receivables that we need, and therefore they get cut. Had that happen in upstate New York when I was working there, where one of the larger insurance companies, that it won't be named, but it was a color, like orange, and they, what? Anyways, they had a nonprofit a hospital clinic in a rural area next to us where we were serving. We had 2 clinics, and it wasn't profitable to them, so they simply cut, they closed it down, and rendered 16,000 individuals in a rural area without access to healthcare services. And to me, it was unconscionable. And so we did everything we could to rally our healthcare resources into that area. But for them, it was simply a matter of the bottom line. So
let me build on that and ask this kind of question, which is, let's stipulate for a second, for the sake of debate, that market consolidation is not only propelled and catalyzed by the Affordable Care Act, and it's not only propelled and catalyzed by market activity, but that maybe it is the only way to get to this kind of scale. Let's just stipulate that for the sake of debate for a second. What kind of demands should we ask of a highly consolidated marketplace in order to avoid some of the shortcomings that can apply in particular communities? In particular, for instance, with the expansion of Medicaid, that has meant a significant improvement, generally speaking, on hospital bottom lines. And in nonprofit hospitals, of which we have many in Washington State, the community benefit requirement is a piece of the nonprofit hospital or nonprofit tax avoidance benefit. In other words, if we think we have to have a consolidated market, should we demand and expect more from the community benefit investment from hospitals that have, generally speaking, done well under the Affordable Care Act? Is that a regulatory step that we should be talking about as a community? Or should we let the people who have amassed, who run a successful balance sheet, figure out how to spend those dollars themselves?
Kind of, Kimberly Kite, I'm a nurse midwife, and kind of going on this and being a provider and how to get providers to go into this provider-based. Having for 14 years worked for the very large hospital, and I'm now being the very small fish, starting my own practice and birth center. Because trying to provide very high quality care under these large healthcare systems is extremely difficult. And then doing what you're saying to do, trying to be accountable to a larger healthcare system, especially when somebody's crunching the dollars, becomes even more difficult. Because you're put on a time clock, you're giving 10 minutes to see your patient, and now you're telling me to perform high quality care and take good care of my patient. Do you want me to make money for your healthcare system and be able to make the bills, or do you want me to perform high quality care? Because those two do not happen in the same sentence. So when you're trying to figure out if you want to do high quality care for these patients, you have to figure out what that quality care is, because we have to shift our focus. We have to shift our focus from you coming in and me fixing your diabetes when you become sick, and start paying providers to prevent you from getting diabetes in the first place. That's how we're going to fix this healthcare system, and that's what insurance companies need to start paying for. Because as a provider right now, I can't bill for that. and I can't fix your diabetes in 10 minutes. So that's where the focus on this value-based revenues need to go to. And if you have a provider who really cares about their patient and providing high quality care, they're not going to join a big system like this.
But yet, big systems we have, right? And that's where a lot of money is.
And that's why, if you look at our healthcare system, we're spending a lot of money, but the United States has some of the poorest health in the world.
Yeah. How do we, if, I want to go back to this sort of regulation question and this accountability to community question that I'm trying to ask, which is, of course, central to Healthier Washington, right? How do we, if we allow or stipulate that consolidation is going to continue to happen, how do we demand more from consolidated providers or consolidated insurers so that the community isn't left out like Joe is suggesting? Sophia, you look like you have something to say.
Thanks.
Do you have any thoughts? I mean, it's a tough question. There's no easy answer.
Well, I think I've seen where large systems adopted hundreds of individual practices, and I think that there was some good in that they provided some guidance and structure for uniformity where it was needed. For example, there might have been staffing guidelines where the hospital actually had data, or the system who took the primary care clinics actually had some data about bringing down some medical errors based on some staffing models. So I think I've seen some good examples there. But I was just thinking when you came around is that sometimes there's just some variability needed, and I think it was the comment from this provider here is that not every patient can be fixed in 10 minutes. And I think one of the issues around good prevention and this care across the lifespan is that there has to be some variability for patients when the provider identifies that, and I guess the mix of goods or services that person needs is just going to vary in order for them to be successful. So there's going to have to be some allowance for that. With that said, when you talk about regulation, it's been a while since I've been engaged in community benefit conversations, but I think what's good is that if there is a reporting some kind of the impact of a system in their community benefit plan, what are those outcomes that shows they're actually making success in the communities they serve? And I think regulation is a good tool so that that would be transparent to the public.
So the other piece of this is obviously the value-based payment side. In Hawaii, of all places, there's a blue plan that has 70% of the market there across all lines of business. And they are moving January 1 to full capitation for all physicians and providers. Even if the onesie and twosie, they're now going to be capitated. And
Two insurers.
well, that's what I say. One has 70% of the market. They're the one that's moving. And so they're taking the argument, Rick, I'm coming to you, that they're taking the line of thought that where the money starts is where the culture happens and where the transformation happens. And we have enough consolidated market power at HMSA to move the whole state to value-based payment. We're starting with docs, we're going to move to hospitals, et cetera. In Washington State, we have much more reticence amongst plans and across all lines of business to move wholesale in that way. And that's in part because providers would leave and go to another plan. There's not that kind of market consolidation. But let me put the spotlight on plans for a second. Do we need more leadership out of plans to be able to get there, regardless of consolidation? And what do you think the community of providers would do if plans and risk-bearing entities moved rapidly in that direction?
So I've been in a fully capitated environment for 20 years, so that's what I live. But I think the piece, there's a lot of attention to the money, and that's important, and the money does drive you to do things, obviously. But what we did before we got into the money was have a system of care. And so there was a system of care defined first that said, this is what we're going to do. Then the reinvestment is naturally going to the system of care rather than to whatever because right now in these community benefit kinds of discussions, it's kind of whatever that entity that's giving the money decides they want to do. And if they want to bake cookies because they think that's a really healthy thing to do, that's what they do. But it may not be what the system of care in a community wants. Plans, I think, could play a leadership role in that. But I think it has to be a community discussion. If you don't have that system in place, then all the other investments become just kind of shotgun.
So let me ask a follow-up there. It dawns on me, you have had essentially a monopoly position on the behavioral health payment side in your regions. You are fully consolidated in that regard on the behavioral health side. Maybe you are able to provide a system of care specifically because you have been fully consolidated. Is that the lesson from the experience?
It's a chicken or an egg thing. In our case, we defined a system of care before we were capitated. And then the capitation allowed us then to build out that system of care. So we knew where we wanted to go. We said, this is what we need to have for a full continuum. This is the models of care. We want to invest in evidence-based treatment. Mm-hmm. And then the lever was, by being capitated, we could reinvest savings. So I don't know which one really causes it.
Yeah. Up here, up front.
Thank you. My name is Ira Sengupta, and I'm the Executive Director of the Cross-Cultural Healthcare Program. We've been doing this work for over 25 years, and we work with healthcare systems all around the country as well as locally, and health plans included. So before I share what I have to say regarding this, I just wanted to give a shout out to Primera. We've worked with them intensely for the last 5 years. And in terms of what SP said, the organization's perspective is becoming more and more patient-centered, and just to say that. And the next thing is to ask you a question. As we talk about market consolidation, and we've seen that in states like Indiana, big corporate hospital systems that have sort of gone into rural Indiana, and they've bought out small community hospitals, and the reverberations, negative reverberations on the community has been ample. So we have experience of that, but I wanted to say that what I hear again and again is the great and grandiose effort to make things simpler, but they become more complex. And I think after they become so complex and in the discussions in the boardrooms, then I think people go back to what is the real issue here, and they say it's the patient. And indeed, friends, it is the patient. This morning when SP said that the patient's voice is underrepresented in this room, I wanted to stand up and say, in fact, it is widely represented in this room. Friends, in this room, how many of you have never been to a doctor? You care to share, but be truthful? I think all of us have, right? You probably were born in a hospital, unlike me, who was born in a home many, many years ago. But the point being that we are all patients at one time or another. So when you're asking the question about market consolidation and all of these very important issues, ask yourselves as patients, what do you care most about? And then ask yourself, when you go to your doctor's office and you're able to communicate effectively, and you're able to say to them, when you're going to get your colonoscopy, that I want an unsedated colonoscopy, and you bargain for it, which I did for good reason. But anyhow, you're able to do that. You're able to negotiate constantly for yourselves and be your own advocate. But the patient that cannot do that is the one that needs the most care, the most attention, I think, at this point. So if you could just anchor your thoughts on that again and again, I think we'll be able to simplify it rather than make it more complex. And again, I want to applaud the efforts that we've seen for 25 years to do just that and provide the best care. So I don't know if that's what you wanted to hear, but I did want to bring that voice.
Great, thank you. So we have about 5 minutes left, and I want to take on the impossible task of trying to find some sense of this conversation, recognizing that we'll fall short wonderfully. But some of the elements I've heard in this conversation, I'll throw out to you. Please correct me or modify. And then I want to kind of get a just general sense about which is sort of the most interesting and compelling, and that which we ought to bring forward to the full group. And we'll do that by a show of hands. So some of the principles or elements I've heard is the importance of culture in this conversation about organizational consolidation and change. I've heard that we have to have enough scale, but that doesn't mean monopoly power. It doesn't mean it's hard to know what that sweet spot is. Maybe between too big and too small. I've heard about sort of the chicken and egg, to Rick's point about maybe it's in some communities it's building the delivery system or the system of care first. In other places maybe it's focusing on finance. Are there other key points in terms of general senses and statements of patient centricity is another one, and not letting that go, though I think that's an important principle. I want to make sure we're focused on our problem statement related to market consolidation and value-based payment, but it is the will of this group in terms of your takeaways. And you're all getting a show of hands here in a second, and they're going to take pictures of it, and we're going to post it on the internet.
Thanks.
Peter,
I think the core question that you've asked is, given the fact that market consolidation is a huge driver right now and is a reality that we need to address, we made the argument about yes, but don't forget the small practices as well. But I think to answer your question more explicitly, what would we demand of the market consolidation model, I think was your core question. One, I would say that we have to have very stringent network adequacy standards. I think that gets at the issue of, don't forget, the people in small to mid-size, don't sort of run them off the road, forget them. All right, stringent network adequacy standards. Very clear, measurable outcome metrics so we can decide whether or not the system is delivering on what it's supposed to be delivering. Some very clear support of the of practices of all sizes, be it large multi-specialty systems all the way down to a small, even solo practice. How do you help them? And that would probably be some sort of functional hub and spoke model. So whereby all of that infrastructure, all of the value that the large system, the consolidated market has at its disposal does make its way out to the individual providers.
So I want to get Peter for a quick, and then Carolyn, and then I want to revisit this. I'm going to ask you, Bob, we have a couple of note takers. Maybe you just rip that out and we could just take your notes specifically. And I want to categorize your comments as something like increased accountability from the healthcare system to communities, or increased government regulatory oversight to ensure the values are not discarded, values of the community are not discarded. We're getting short on time. Peter?
Thanks, DJ. I think another theme that was kind of traveling through a number of the comments was that what we really need in an environment of, it's not about consolidation or not consolidation, but we need standardization of information and of data. The absence of an infrastructure of interoperability, first, that everyone has EMRs and digitized information, and second, the absence at the moment of interoperability where that can all be shared is, I believe, more critical than consolidation or not consolidation. But in order to deliver community-based care, whole person care, there's got to be a full data set that today we don't have and that consolidation doesn't bring.
Right. Carolyn, last word, and then we'll revisit this question.
Boy, Peter, I couldn't agree with you more. That's right on. I also think we have to say that the big fear about consolidation is price, cost. When systems consolidate, prices go up. And so it's incumbent, to add that to the cost equation. And some way you've got to control it. Probably not regulation, maybe more about contracting. And how do you get the best contract for the services that are delivered? And there has to be an element of risk-taking. And that's difficult for providers, and I think it's especially difficult to get providers to join, systems if they're not, really married to that system. So I think that's confounding.
So let me try to consolidate all of this into a couple of statements that are just very loose. These are not, we're not going to sort of wordsmith by committee and all that stuff. These are very loose sentiments that I want to reflect back to you. And then, I'll sort of rattle through these, and then I want you to all just sort of say, yeah, that's, I think, the one or two things. You can vote for one, you can vote for two, but you can't vote for three. One or two things that I would want this group to take forward. So the first is the central importance of culture. It's not really about consolidation or VBP, it's really about fostering culture. That's one statement. I'm going to take Peter's statement on standardization of data and infrastructure. I'm going to take Rick's statement about sort of the system of care piece. What other ones did I want to speak to? Bob's sort of regulatory accountability and regulatory oversight of this. Was there a fifth that since I'm doing this on the fly? I'm going to put that in as the regulatory oversight piece rather than standalone. Joe, your comment was about community accountability also. Is that how I can categorize it?
Yeah, or
Okay.
sustainability, retainability,
Okay.
sustainability.
Okay, I'm going to make Carolyn's second one on price and yours sort of fifth. Okay, so culture, standardization of data, regulatory oversight, Bob's comment, system of care design, essentially important, and then sort of concerns about price and sustainability. So show of hands for the first, the essential importance of culture in this. Let me see it. So I'm going to call that about, well, let's go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Great. Standardization of data and infrastructure. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 2, 3, 4, 5, 6, 7, 8, 9, 30, 1, 2, 3, 4, 5. Standardization of data and infrastructure, accountability and governmental oversight. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Designing a smart system of care, and then it's not about consolidation. It's about getting all the players together. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. And then fifth was sort of concerns about price and overall financial sustainability related to market consolidation. 1, 2, 3, 4, 5. Right? 1, 2, 3, 4, 5. We'll call it 6. Great. Well, I'm going to take those top two and butcher them from the stage, and hopefully do my best to reflect your input. Thanks, everyone. Get up, walk around, stretch out. We'll be back here in a little bit.